Hi, I'm Rich Brown, Director of WIPHL.
Hi, I'm Dr. Heather Huang. I'm one of the consulting psychiatrists who's working with WIPHL.
I'm Mia Croyle, and I'm the Director of Operations.
I came to BSI and MI 23 years ago.
As a medical student, my career choice came down to family medicine and psychiatry. And I decided on family medicine because I really enjoy dealing with behavioral issues in more of a mainstream, healthier population. But I was really surprised when I finally got out of training and into practice, there just wasn't time to address these issues.
Rich Brown and I spent a lot of time trying to get physicians to do a better job helping their patients do something about their alcohol and drug use problems.
As a faculty member, along the way I did a bunch of research and teaching on behavioral issues, especially alcohol and drugs, but I always felt guilty that I really wasn't doing much systematically about these issues right at home in my own neighborhood, in my own clinic. Then I was fortunate to be able to help the state of Wisconsin get a grant, which actually led to the birth of WIPHL.
One of the things that I find most rewarding about the work is that it offers us the opportunity to really intervene with patients earlier than we often do when they're struggling with behavioral health issues.
Collaborative care is a form of integration of behavioral health services into the primary care setting. Traditionally, most services are separated, so if you need mental health services, you would go in to see your primary care physician, and then they would refer you to a psychiatrist if you needed to see one. That also involves going to a different building, meeting a new provider. The neat thing about collaborative care is that it's an innovative model that allows your primary care provider to work in a team with a health educator as well as a consulting psychiatrist.
I had many more opportunities to see BSI MI in practice. I got to use it with more patients. I had the opportunity to share and train this with fabulous health educators and hear their stories of success, their stories of how this was impacting the lives of the patients that they were working with.
I came to WIPHL a little over 6 years ago, and actually my first role with WIPHL was as a health educator in a clinic. And I am so glad that that was how I was able to start my path with this program. I found it really rewarding to do that work.
We've been able to screen over 100,000 patients in dozens of clinics around the state and finally brought to life the realities that behavioral screening and intervention could bring.
It was that standing alongside them, that helping them figure out what their strengths were, what their values were, what their goals were, and how drinking was or wasn't fitting in for them, and helping them come up with their own conclusions with no judgment, with no pushing them towards one thing or another, that seemed to be helpful to people.
One of the great things about collaborative care is that patients can receive mental health services in the setting of their primary care doctor's office. This really improves on a lot of the barriers, and it also importantly addresses stigma. Stigma is a huge problem with mental illness and is a very large reason why many patients don't show up. They don't want to be labeled as having behavioral or mental health problems. And being able to go to their primary care doctor's office for any mental health needs really can help overcome some of these barriers.
And one of the things that was exciting to me about the idea of BSI was that it offered us the opportunity to intervene in people's lives earlier on. I think primary care is perfectly situated to help identify patients who might be starting to have problems much earlier than we typically do. We typically don't recognize patients until they're really experiencing a lot of consequences and suffering and harm as a result of their concern. And with BSI, through systematic screening of patients, we're able to identify them earlier.
Studies have shown that behavioral risks and disorders are actually responsible for 40% of deaths and most chronic disease among our patients. When I would take my turn a couple of times a year taking care of our patients in the hospital, I kept an informal tally, and I usually found that about 70% of our hospital admissions could be traced back to at least some behavioral issue. And of course, hospitalizations are the biggest ticket item when it comes to healthcare costs. So it's really clear that if we systematically address these behavioral risks and disorders, we'll be able to prevent a lot of hospitalizations, improve health of our patients, and decrease costs by a lot.
And that's been one of the things that I think the clinics have found most satisfying, is that they're able to do a better job at taking care of all of their patients' needs, not just the ones that they traditionally would identify as their physical health needs.